Good afternoon, dear colleagues. It's really a great pleasure to be here with you today, and also a great honor to give this Paul Bacon lecture, because I was a good friend of Paul Bacon and inspired a lot of works on vasculitis and treatment of vasculitis. Today, I would like to make an update on vasculitis treatment, but at the time of COVID-19 pandemia, because it could change some things and many things in the future. Here are my links of interest. And this first slide, in fact, is a great souvenir for me and also for Wolfgang Gross when we were together with Paul Bacon and Hemant Sharma in Chandigarh for the Iraqan 2014. We had a very good time. We learned a lot of things, and I'm sure that this Congress will be also very good for everybody, even if I'm not in India, but in Paris, in my home. I will divide this talk in three parts. First, the update on induction treatment. Second part, maintenance treatment. And third one, rituximab and COVID-19. Some major events in vasculitis should be underlined. First, cyclophosphamide as a treatment of vasculitis was described in 1979. It was oral treatment at that time. Later on, discoveries of viruses as a cause of vasculitides, and it is clear and well demonstrated in polyarteritis nodosa for hepatitis B virus and HCV virus in cryoglobulinemia. The ANCA were described in 1985, and for the first time, it was possible to understand some more modern pathogenesis of the disease, but also to have a diagnostic tool and a classification tool. And it was completed by Jeannette in 1988, when he described anti-MPO antibodies. And at the end, we have the Chappelli nomenclature. This nomenclature is very important because now we understand how to classify, how to describe vasculitis. And the treatment is more a tailor-made treatment adapted to each vasculitis, and it is based on this classification. When we look at the induction treatment in vasculitis, and more specifically in ANCA-associated vasculitis, we have two parts. The first one is induction treatment. Duration is 3 to 6 months with pulse or oral cyclophosphamide. Pulse cyclophosphamide was promoted by Paul Bacon and I many decades ago now, but we know that it is largely spread all over the world and that many physicians use this pulse cyclophosphamide because it is a safer treatment for patients. Maintenance treatment occurs after remission has been obtained, and we treat approximately 2 years, and we will see that we have probably to choose the optimal duration of treatment according to some patient's characteristics. Azathioprine or methotrexate are the leaders. The other drugs like mycophenolate mofetil are not so effective, and rituximab will be the next chapter. We proposed in 1997, we published in 1997, the first randomized trial comparing IV to oral cyclophosphamide in venous granulomatosis. And as you can see, the remission was obtained in 88% in the IV group and 78% in the oral cyclophosphamide group, no difference. But the number of relapses at 4 years with a similar maintenance treatment was different. It's 59% with IV, 30% with oral treatment. On the contrary, side effects were more frequent when treatment was an oral treatment. And we concluded that pulse cyclophosphamide was as effective as oral to induce remission, but less effective to prevent relapses. But now, with a very good adapted maintenance treatment, we could and we can treat patients with pulse cyclophosphamide initially, and we obtain quite a good response with a very low toxicity, because also in elderly patients, we have treated patients with only 3 grams cyclophosphamide IV to obtain the remission. In fact, cyclophosphamide, when prescribed to induce remission, should be followed by a maintenance treatment. We know that, and we know that for decades. This slide and this trial is very important. It's a Cicazarine trial comparing a long treatment with oral cyclophosphamide, 1 year, to a short treatment of oral cyclophosphamide, 3 to 6 months, followed by azathioprine. And among this group of 150 patients followed for 18 months, we observe exactly the same curves. And it means that it is not useful to give a prolonged treatment with oral cyclophosphamide, and that only a short treatment is enough to obtain the remission after this good induction treatment. Regarding maintenance, in this trial, published also some years ago now, we induced the remission with IV cyclophosphamide, and we compared azathioprine to methotrexate for maintenance and during 1 year. The results which have been obtained are displayed on this slide. On this cartoon, you see that both treatments have exactly the same efficacy. But I would like to show you that, in fact, at 3 years, 36 months, approximately half patients had relapsed, which means that even when induction has been effective, maintenance treatment is associated with many relapses when conventional treatment is proposed. And for this reason, we looked at different treatments, some for induction, some for maintenance, and it was a story of rituximab. In this study, made by Stone and colleagues in the United States and published 11 years ago now, the comparison was made between the conventional arm, steroids and oral cyclophosphamide, 3 to 6 months, followed by 1 year of azathioprine. In the other group, rituximab only, 4 infusions, followed by a placebo of azathioprine. And the comparison which was made is shown here. The first analysis was done after 6 months, and another analysis at 18 months. This study, called RAVE, demonstrates clearly that there is no difference between the rituximab group and the cyclophosphamide group. And it is a non-inferiority study. Rituximab is as effective, but it is not a mistake to treat a patient with cyclophosphamide. And in my group in France, we have selected the patients who receive rituximab for induction and those who are controlled and treated with IV cyclophosphamide, not oral. This slide is very interesting because it showed what happened after 18 months. You can see that there is no difference between both arms. And in fact, when patients have been treated initially with rituximab, they have exactly the same number of relapses that if they had been treated with oral cyclophosphamide followed by 18 months azathioprine. And it could be a temptation not to treat the patients for maintenance and to give only IV rituximab initially. But what we observed is that at 18 months, approximately 40% of the patient relapsed. And for us, it is not acceptable. And we demonstrated that a maintenance treatment is useful. If we summarize, the therapeutic options after induction treatment with rituximab are again rituximab, and I will show you that it is effective, no treatment and wait for the relapse, or to give an immunosuppressant like azathioprine, for instance. Azathioprine and methotrexate are not so effective, but they are a little effective. And the main recent study was certainly an important one, because for the first time for maintenance, we compared rituximab to azathioprine. Patients were induced by IV cyclophosphamide for the majority of them. They were in remission, and we compared 2 milligram kilo per day azathioprine to pulse rituximab. And this pulse rituximab, this infusion, now we do not give the 2 week, the second one after 2 weeks. We treat every 6 months, and it seems to be really enough. And with low dose, 500 milligrams, which is not so much for the patient. The analysis was made after 28 months. In azathioprine, 28% of major relapses. In rituximab, with rituximab, 5% major relapses. Clearly, rituximab is more effective than azathioprine to maintain remission. The outcomes in the long term, here it is at 5 years, the same study, is very good. No deaths in the rituximab arm, and a few deaths in the azathioprine arm, which were not, except for one of the 4 deaths, related to the vasculitis or to the treatment. What was of interest is also what about the comparison of the 2 groups, rituximab and azathioprine, in terms of relapses. You can see that with azathioprine, patients relapse a lot. It is a red curve. But when you look at the rituximab arm, they relapse also. Not so much, but they relapse. And it means that some of them probably deserve prolonged treatment. And when we analyze the subgroup of patients, we can see that those who are PR3 positive at 12 months and, of course, at day 0 relapse a lot. Those who initially were anti-MPO or who did not add any ANCA did not relapse or relapse very rarely, but they relapse sometimes. And in between, you have the intermediate group made of patients who were initially anti-PR3 and who lost the antibody during and after treatment. It had been shown also previously, before our study, by our American colleagues who showed that the relapse rate was directly related to the presence of the ANCA, of the subtype of ANCA, anti-PR3, and not anti-MPO. To try to optimize treatment with rituximab, we proposed 2 other trials. One was the maintenance regimen called MENRITZEN-2, and in this trial, we compared MENRITZEN-1 to an on-demand treatment. We monitored the CD19 and the titer of ANCA, not the presence, the titer of ANCA, every 3 months. And if patient had an increase in the titer, or if CD19 reoccurred, we pulsed again. And when we compared at the end of follow-up, which was 28 months again, in the on-demand group, patients received 3 pulses rituximab only, which is not so much. 3 pulses of 500 milligrams each. The number of relapses is not significantly different, and the number of major relapses is not significantly different. But if we look at the interest of ANCA titer does not predict relapse, and the absence of CD19 does not predict a remission or protect against relapses. In fact, we have to find the good criteria, and as I showed previously, the presence of ANCA is more important than the titer of ANCA, and be very careful with the CD19, which are not the guarantee of no relapse when the immunosuppression is still present. In the MENRITZEN-3 trial, we re-randomized the patients belonging to the previous group, MENRITZEN-2, and they received again 4 infusions every 6 months of rituximab, followed by a placebo. You can see the difference. More you treat, less relapses occur. And you see the difference between the placebo group in red and the rituximab group in black. A similar trial was organized by the UVAS and the VCRC in the United States, called Ritazarem. In Ritazarem, the patients at inclusion were more severe than the patients belonging to the MENRITZEN-1 trial. But the dose of rituximab is very high, 1 gram every 4 months. The results obtained at the end are quite comparable to what we showed previously, azathioprine versus rituximab, a clear difference in favor of rituximab. And we do not know a lot about the side effects, infectious side effects observed in this treatment. And if I would conclude on this part of the talk, I would say that rituximab is the best option for maintenance, no doubt. Longer you treat, better you reduce the relapse rate. But rituximab indication should be chosen wisely. Probably that we should not treat all patients for years. Those with anti-PR3 at day 0 and 12 predict relapses and should be treated for years probably. But patients without ANCA relapse less, and maybe that a treatment of 2 years is enough. And it is the same for the anti-MPO patients, and usually we stop the rituximab when they are anti-MPO, we stop after 2 years treatment. And in fact, it is possible to select the groups who need a prolonged treatment and those who do not need that. But do not forget that rituximab, like other biotherapies, is a suspensive treatment, and relapses may occur. When immune reconstitution has occurred, the risk of relapse remains present. Prophylaxis by cotrimoxazole against PGP is compulsory because approximately 1 to 2% of the patients will develop pneumocystis carinii pneumonia during or after stopping treatment. Immunoglobulin become very low, as you know, but it's mainly IgM. And usually we do not substitute and compensate this immunoglobulin low level because patients have low immunoglobulin, low antibody, but they do not make the infection. But something is changing now, probably with COVID. And the last part will be devoted to COVID-19, and I will start with a description of this study, which is an international study with a large group of patients, is retrospective, 1,200 patients with different vasculitis, mainly ANCA and GCA, some Behçet's, and a lot of miscellaneous vasculitis. When you look at the characteristics of poor outcome, you see that there is some different characteristics, but I would like to come back and to comment on this one. Yes, the analysis was made with 1,000 patients. And what is very, very important is to see that if the majority was not hospitalized and could stay at home, those who were hospitalized, approximately a quarter of them were ventilated or received oxygen, and the death rate was high, 15%. And when we compare to the overall mortality in our countries with COVID, which is approximately 1%, it is really a lot. And patients that we treat with steroids, immunosuppressants, and rituximab for vasculitis really are at risk to develop a very severe disease. The characteristics of the poor outcome are the age of patients, the comorbidities, the dose of prednisone, and the activity of the disease, and male sex, but I have not a lot of information on this part of the outcome patients' criteria. In fact, we know that it is difficult to reduce comorbidities. It is difficult also to treat patients without immunosuppressants or without rituximab. But we can reduce the corticosteroid dose and duration, which is a good help for patients. This is the PEXIVA study, and which was a double randomization, one on plasma exchanges at induction, but I will not comment on that, and the other one of glucocorticoids with lower dose. And see only the right of this slide, and you can see that the survival rate is the same between patients receiving high dose, standard dose of corticosteroids and reduced dose. It shows that when we treat patients with corticosteroids, probably that we could reduce the dose of corticosteroids maybe by half during the course of the disease. And we have many efforts to do for this. And do not forget also that to reduce corticosteroids is a point, but it is also, could we stop corticosteroids? In the United States and in many countries, steroid treatment is very short. And it can be longer. For instance, in France, where we try to treat 18 months to 24 months, but the second year is only 5 milligram corticosteroids. And in this retrospective study by Walsh in Canada, you can see that the number of relapses is quite low when patients keep a low dose corticosteroids, and there is some relapses when they stop corticosteroids. We do not have now prospective studies to validate this hypothesis, and there is different trials all over the world to make a very quick withdrawal of corticosteroids, one organized in the United States and the other one by the French Vasculitis Study Group. What about rituximab and COVID-19? There is some new information because patients treated with rituximab, we know that they do not produce antibodies after vaccination against COVID infection. Patients treated with rituximab should be treated prophylactically against COVID. And what we have started now is to use Ronaprev. Ronaprev is a monoclonal antibody, a combination, in fact, of two drugs. And it can be prescribed before COVID exposure, and patients will develop only with one infusion antibodies for a few months. We don't know if it will be useful to give a monthly infusion or if we can wait. We are just in the process of evaluating that. And we know that many drugs are expected soon, that the next one, probably before the end of December, will be by AstraZeneca in Europe. And a new vaccine injection should be done also. Vaccine, we know, unfortunately, does not increase the rate of antibodies against COVID, but probably that it stimulates cellular immunity. And what we see now is for the maintenance treatment, we should make the choice of rituximab. For induction, we have some space between cyclophosphamide and rituximab. But in the long term, we have probably to define the population of patients who need a prolonged treatment with rituximab and to define the population in whom we can stop treatment. And because we have the pandemia now, but also to prevent the other infections, many prophylactic measures have to be established, to be done. And among them, vaccination, certainly, prophylactic drugs, tuberculosis, some viruses, and of course, antibiotics for pneumocystis. And we do not forget the new drugs against COVID-19, which are now available in some countries. I thank you very much for your attention.